My name is Busra Demirci. I'm actually here from South Florida. So when people hear Florida, a lot of times they're like, oh, so you're like near Disney World. Not exactly. I'm like more south, Miami-ish area. And they're like, okay, Mr. 305, dale. Not that either, although he's a nice guy. We actually have a really big tech scene down in South Florida that I love being a part of. And for the past 5 years, I've been a part of an awesome company called Modernizing Medicine, which is a healthcare technology company that focuses on making doctors' and patients' lives better through technology. I've had the opportunity to focus on streamlining that for patients, doctors, and clinicians throughout the entire United States. And I've assisted in actually creating national patient safety standards and clinician experience standards for the entire health IT community, which has been pretty fun. In the fall, I will actually be working on an initiative with the NASA team. For those of you that have heard of an event that is near and dear to my heart was the Parkland shooting that recently happened near me. I took the opportunity to speak to the NASA team, and I'll be assisting them in their innovation lab to create an extended reality experience that enables disaster response teams to assess mass casualty incidents and assess victim injuries in real time and provide them with treatment for those injuries. And I'll also be joining the fantasy team to work on innovative initiatives for other UX things as well. So what I'm calling my talk today is a tough pill to swallow, and you'll understand exactly why that is in a minute. I want to start by introducing all of you to the healthcare ecosystem. So the internet and mobile devices have magically sprinkled pixie dust everywhere to solve so many problems in the world that we have this notion that computerization in healthcare is going to be similarly straightforward. Give them an iPad, give them a phone, give them a computer. It'll fix all the problems. It'll take all the paperwork away. Yet, when computers were actually introduced into the world of clinicians, things didn't quite pan out the way that they expected it would. Doctors' visit notes were bloated, indecipherable. Doctors and patients stopped looking each other in the eyes when you're actually going into the doctor's office. And they still use faxing as a method of secure communication. I don't even own a fax machine. And it's caused a lot of challenges that lead to what's called in the industry now as physician burnout. The national statistic, it's a global statistic of physician burnout is 1 in every 3 physicians experiences physician burnout. This leads to increased error, increased risk for malpractice. Burnout on the doctors actually has led to drug and alcohol abuse, and what's not publicized is they actually have one of the highest suicide rates among other professions due to the stress and burden that has been introduced through the increased technology and the increased necessity for accuracy in ensuring patient safety. That's kind of scary. And what does that mean for our population? Well, I want to illustrate that to you by telling you the story of a boy named Pablo Garcia. Pablo Garcia is a 16-year-old boy who was admitted into the UCSF hospital on July 27, 2013. He went to the hospital complaining of numbness and tingling all over his body. He had no idea what was going on. He had some other health problems, but he couldn't decipher it. So he went in, the doctors looked at him, they said, all right, we're gonna administer you some drugs, you'll be great to go, and we'll get you out of here. They gave him steroids to help his immune system, they gave him antibiotics to get rid of his infections, and when they went back to go check on him at 9 p.m. that night, they expected him to be feeling better. Yet instead, Pablo's symptoms amplified, and he was saying that he's feeling numb all over and began having seizures. Why? He was given medication. Medication fixes people, I think. Clinicians were perplexed. They had no idea what was going on. They were looking through all of his notes. They're like, we gave him all the right things. And then they found something that stopped them cold. The physician that had placed an electronic order for Pablo's antibiotic had failed to notice that the order on the screen was set to calculate the amount of drug based on weight of the patient instead of accepting the total milligrams of the dose. So what that means is, in the software, they were expecting a dose that would have been in milligrams, but the software had it set to milligrams per kilogram. And so when the doctor went in and entered the number 160 milligrams, the computer multiplied that by Pablo's weight. Okay, but can we fix him? Can he get better? It's a drug. Maybe he'll be better. Was he okay? That night, Pablo Garcia was given a 39-fold overdose of a routine antibiotic drug that cost him his entire life. And I'm sure you're like, okay, but we're in America. America equals advanced. How could this happen? We have the most state-of-the-art hospitals. They're all equipped with the best healthcare information technology money could potentially buy. They have computers. They have technology. Why? Why is this happening? Well, the thing is, the computer caught the problem. The computer and the software alerted the doctor that this was an overdose. The doctor clicked out of it. Then, when the prescription got sent to the pharmacy, the pharmacist was alerted. It's an overdose. The pharmacist clicked out of it. Okay, that's messed up. Why? That makes no sense. The computer told them that it's an alert, that this is bad, fix it. As an outsider, that might be what you're thinking. Yet, Bob Wachter did some research at the UCSF institution, and he found that within the period of 1 month, doctors get 30,000 alerts, pharmacists get 160,000 alerts, and the 70 intensive care units that are used to record your heart rate, blood pressure, etc., throw off 2.5 million alerts to the point that there's an audible alert within the hospital every 6 to 7 minutes. There's just background noise going, constantly blaring. I don't know about you guys, but I get alerts on my phone all the time, and I'm just like, ignore, ignore, ignore. Because of fatigue. Because you're fatigued and you don't have the time to read through all of these alerts because you're alerted of everything. The technology is alerting you because that's easy to do. Throw an alert, throw an alert. And you create this burden and burnout. So if there are these many alerts going on, Bob asked one of the nurses, how do you even know something's important if you have all this background noise? And the scary thing was the nurse responded silence. If there were no alarms going off, then I'd be really worried. Think about the implications behind this. Today, we have figured out that, okay, if this drug and this drug interact with each other, we'll throw off an alert, and we'll let the doctor deal with it. But this shows zero understanding of human factors or any kind of user-centered design. You're not taking into consideration the ecosystem or the environment that this doctor is working in. There are distractions, there are artifacts, There are things going left and right. Their brains are filled with information. Empathic design doesn't just throw an alert and then multiply that alert by thousands and thousands. So a great way to illustrate this is what's called James Reason's Swiss cheese model of error. We were just actually talking about it over coffee this morning. I do love cheese. But the Swiss cheese model of error actually holds that complex organizations harbor many latent errors that are unsafe conditions, in essence, that are mistakes just waiting to happen. And when you introduce technology, right, just like the computer, just like the iPad, you then need processes, right, to take care of whatever that technology is. And you also have people to interact with those processes and with that technology. Yet still, there are legions of errors every day in complex organizations that don't lead to major accidents. Why? Because organizations have actually built in protections against glitches from causing things like nuclear meltdowns, plane crashes, train derailments. But introducing more and more of this, multiplying it, is like a forest carpeted with dry underbrush, just waiting for a match to light that strike. And once that strike happens, a hazard is introduced, and it leads to a loss. The protective layers that all of these institutions have in place have holes in them, just like Swiss cheese, which is delicious, but not in this context. And James Reason, a lot like when stars align in the universe, holes align in the Swiss cheese. And when those align, we get problems. It was $30 billion of government funding that introduced a 70 to 80% adoption of technology in the healthcare space. This is actually a huge level of adoption because doctors and clinicians are one of the latest adopters of technology. And that's because they're so busy and their workflows are so fragile that they don't have room for error. They don't want to introduce error. They don't want to introduce those hazards. And when you look back at the Swiss cheese model, the more technology, the more processes, the more people, the more hazards and losses. It's why we hear about these all over the news every single day, right? We hear a malpractice lawsuit here, we hear someone who lost their life there. These are errors that can't be prevented. And with that government funding actually came really tight-knit regulations by the government that have brought a lot of red tape to the healthcare industry. If any of you have experience in the healthcare industry, there are a lot of different rules and regulations that you need to tiptoe around. And this ended up stifling the pace of innovation in the industry. So introducing the healthcare industry to the era of technology was an amazing first step. Not saying technology is bad. It was great. But when all the rules and regulations were being defined for the requirements of a modern healthcare system, they forgot a critical piece: the user. We all interact with the user. We know that you can't build something for someone who's going to use it without understanding how they work before introducing that thing. That's where we all come into play. Not just in healthcare, in everything we do. In every industry, we can make a difference. We can change the world. Up until this point, computer vendors making these systems haven't brought physicians, nurses, medical assistants, pharmacists, or patients into that process. The next step is actually applying user-centered design to make them a part of that entire conversation, giving them a seat at that table. At my current company, Modernizing Medicine, we actually employ doctors, medical assistants, nurses, ex-clinicians on staff to have them right next to us coding and designing the software. In addition to all of the ethnography, the empathic design, the research, the validation, because it's extremely fragile. And a lot of us are already starting to see this applied in many ways, big and small. We're all patients. We've all been to the doctor. This is a recent project I worked on. I was designing and making a patient portal that wasn't completely painful, for those of you that may have access to one. I wanted to give the patient more control and awareness of their health, and an easier way to facilitate a conversation between the patient and the doctor to ease them. By listening to patients and using a human-centered design process, I focused on intelligent processes that ease information overload and think for them on the back end, that result in a streamlined system. So you can see here actually in the video, we own the entire ecosystem of products. And what I did was work together with my team. We put together this video. We spoke about everything being streamlined, everything being electronic on the back end. The patient walks in, they use their fingerprint to log into the phone. A beacon automatically syncs with Bluetooth across the entire doctor's office, and everything speaks to one another. They walk in the room, they know where to go, they're guided on where to go. They speak to the clinician. The clinician is eased because they know where to go. They can use voice commands to control the software instead of digging their heads and burying them in a computer. They don't have to think about, oh, do I have to click this? Do I have to click that? They can walk through all the way up until where they need to go when they're leaving the office and then follow up outside of it, right? And this is just a small example. Another example are some of my really favorite innovations that apply to most recent technology around machine learning at the bedside of a patient. And this is Ochsner Health. They're using complex predictions to send meaningful and only necessary alerts to doctors, which could have saved someone like Pablo. They are actually shifting the way that doctors are assessing problems to know what it is before it even happens. This is a total game changer because the data models that they're embedding directly into the ecosystem with vitals, monitors, and other things are tracking the data and combing through hundreds of thousands of different data points that humans don't have the capability of digesting in real time. Now, add on some AI that can take these data streams and then translate them into real time for patients and clinicians to interact with and provide value-based care, a better level of understanding of medicine, and an easy workflow. So innovations like these are pretty cool, and I get really excited because we're actually changing the world slowly. It's happening. But there are still a lot of people out there who don't have access to money and resources to utilize these kinds of systems. Innovation is not supposed to have borders, and it's not only for the wealthy. Nearly half of the world's population, which is about 3 billion people, live on less than $2.50 a day. $2.50. My coffee costs more than $2.50. More than 1.3 billion actually live in extreme poverty on less than $1.25 a day. And 1 billion children worldwide are living in that poverty. According to UNICEF, 22,000 children die every single day due to poverty. And in emerging countries and impoverished areas of even the United States, you don't have access to patient information. It's not just about the money, it's also the access to the data. The money means nothing without the data. And data means nothing unless someone sees it. We all have the social responsibility to seek out opportunities to increase the accessibility of such solutions worldwide. You can do this in all the industries. Accessibility doesn't have borders either. How many of you have seen this thing before? Yeah? Majority of you. For those of you that haven't, I'm glad that you haven't had to. This is a vitals monitor. Stasis Labs is a great example of making innovative technology accessible to those who can't afford it and those who fall under that poverty line. According to Stasis, 75% of injuries and deaths that happen within hospitals happen to patients who are vulnerable and lack medical supervision. So our hospitals use these really expensive vitals monitors to ease that tracking process. And they work a little bit for the most part. But this machine, generally made by Philips and GE, leaders in the industry, cost a lot of money, up to $10,000 for the device itself, and then $30 per day in operating costs for one machine. Multiply that by like a lot of patients, and it gets very costly. And they're complicated. They look simple, but they create complexity in tracking and alerting and things of that nature. Dinesh Seemakirti, and I might be butchering his last name, was a student at USC who founded the company Stasis Labs after his grandfather passed away in India due to medical negligence. The doctors had missed a deterioration in his grandfather's vital signs because they didn't monitor him accurately. And so what he did was he sought an opportunity, and he designed and built this modern-day vitals monitor that a patient can actually understand and that impoverished regions can afford and utilize at 1/10 of the cost of current medical devices. This costs $500 and only less than $5 per day to operate, which is a fraction of its competitor. The other problem is monitoring vital signs for patients outside of the ICU. Intensive care units already have all of these guards in place because they're intensive care units. A patient's condition outside of the ICU could decline within the matter of a few seconds. And the ICU vital sign monitors focus on live monitoring. But people outside of the ICU are not receiving that intensive monitoring. So Stasis helps fix that by making it accessible everywhere. These are just some examples of healthcare, but we can all seek these opportunities. The opportunity that I sought out actually with NASA was triggered by the incident that happened near and dear to my heart. And the mass casualty response tool I'll be creating is to help prevent that from happening again. And even if it does happen again, to assist and help those individuals recover in a timely manner. So what I want you all to take away from this is that problems are always going to be out there, but it's our job and our duty to seek these opportunities and make a true difference in the world. So if you guys can like humor me and everybody stand up. Come on, come on, come on. You can do it. You can do it. I want us all to say this line together. Ready? Don't. Come on, louder, guys. You guys had coffee. There was some good snacks out there. Don't wait for the movement. Be the movement. Thanks, guys.